This is a brief discussion of some of the injuries in lower legs and rehab concepts of the lower leg, ankle, foot stuff. Have your book out. I got mine out. I'll be following along. Please follow along, highlight, take some notes as we go. And I think it looks like we're in chapter 22. And so let's get started, right? So let me get this thing to click. There it goes. So the first part of this, all your chapters start with this functional anatomy, but I just wanted to draw your attention to it and go, look, I mean, it's important to know the compartments of the lower leg, what muscles are there, what they do. I'm not going to necessarily ask you that, but your book is a good reference. It's a good thing just to read. It's a short section. Go over and read through that. Make sure that you understand what these muscles are that we're talking about as we go through there. For the most part, this is, we're in the lower extremity, so this is functional activity. So closed kinetic chain are going to be, I picked basketball because I like basketball. Whatever your functional activity is, it's going to be on the closed chain. So we transition at some point. We have to transition from our open chain to closed chain activities, running, side shuffling, balancing, doing those kind of things. Balance is key. We start here. We definitely start with some basic strengthening exercises, but we always have to work towards, all right, now let's start strengthening while we are in a closed kinetic chain. And then we start doing much more dynamic stuff, balance stuff, and much more functional activities. And then the other thing that I want you to know is making sure that there's a lot of endurance muscles in there. There's a power muscle in that lower leg, and so just making sure you know the characteristics of the muscles. When do you want to do the eccentric? Eccentric sometimes is a point of confusion. If you look at this picture right here, this is very important. We're doing an inversion, so posterior tibialis is concentrically contracting here. As we let it slowly back, right? As we let it slowly back, that's when you get the eccentric exercise. We still move to a closed kinetic chain on eccentric exercises. So again, we're talking about gastrocsoleus, little heel raise. This is our gastrocsoleus going. We can do it in a bent knee to focus on the soleus. We can do it in a straight knee. But ultimately, this heel raise or calf raise, this is the concentric portion because we're plantar flexing. As we slowly dip down in and lower ourselves, that's the eccentric portion. So make sure it's very important to make sure you have that. All right, let's get to the actual injuries. The first one up that I want to talk about is medial tibial stress syndrome. We've had a discussion on this. We've had a presentation. Go to the handout that you got and look at that stuff. There's a lot of good information in there. On page 717, just like you heard in the presentation, the pathomechanics section and the mechanism section definitely talks about the soleus and the tibialis posterior. Definitely talks about that excessive compensatory pronation and where that occurs. If it occurs in the wrong time, if we're hyperpronated when we shouldn't be hyperpronated, we've got problems. So make sure you have a good grasp of that. And then from a rehab standpoint, a lot of the stuff that your book has was in that presentation. It's in the handout. There was a lot of reference to flexibility of the gastrocsoleus. There was a lot of reference to that single leg balance, strengthening the inverters, everters, that kind of stuff. So we do a lot of these things here where we can do these are functional. This is obviously a little bit down the line in the single leg balance. We start probably on a stable surface. Then we start putting a weighted ball here. In this case, we can start asking this person to do functional activities in there. We can actually ask them to do strengthening activities in a single leg balance. But balance becomes because it's challenging those inverters, everters to maintain their endurance, right? So these are endurance muscles to control the ankle, to control that pronation, supination as we go. All right. Achilles tendon rupture. So I kind of skipped over the Achilles tendonitis and tendinopathy. Basically, the pathomechanics and mechanism of tendinopathy is the same for all tendinopathies. It depends on where it is. And a lot of the exercises and rehabilitation are going to be similar. So I just jumped to the Achilles tendon rupture. I'll hit the pathomechanics real quick. This is on, what did I say, 721? Yeah, there it is. So under the pathomechanics and mechanism, it does talk about that area 2 to 6 centimeters proximal to the insertion of the tendon on the calcaneus as that avascular area where these things most commonly happen. Again, the mechanical stuff or some risk factors here is, again, there's that pronation, tight gastrocsoleus, and how, make sure you know how a tight gastrocsoleus, it decreases the amount of dorsiflexion, which puts us in a more compensatory pronation situation. All right, let's see. Injury mechanism, I see all that. Page 721 has a good description of all that. So please read through there. Don't just take my word for it on the PowerPoint slide. As we get into the rehab concerns, the big thing that your book talks about is the decision of surgically repairing it versus just immobilizing it and letting it heal. There is kind of a shift going on. It's more common now to get just an immobilization, let it heal, let the tissue heal, as opposed to surgical techniques. They both are, and so depending on the physician that you'll interact with, you may see either of those. Either way, you're going to, when this person has the rupture, you're going to send them to the physician, and then you'll get back protocol along those lines. Ultimately, what we do, though, is at some point, whether they just come out of an immobilization or they just come out of a surgery, it's pretty much the same thing. Once we get that tissue to heal, once we get tissue healing and allow for that, we're definitely going to start in some pretty easy open chain activities. But then we have to start getting that Achilles tendon to not only lengthen out and have the extensibility that we want, but also be able to take the amount of force. In there, I think it was, I'm looking back at the Achilles tendinopathy, the amount of, where is it? It's somewhere in this dang textbook about how much, where is it? I can't say. It's somewhere in here. If you read it, you'll see of how much how much force is actually placed through that Achilles tendon. It's ridiculous. So we start with some eccentric loading. We want to work towards this closed kinetic chain, and then ultimately we're treating the cause. So if it's because of compensatory pronation, then that's what we're gonna try to attack and try to prevent that from happening again. All right, so as we go into chapter 23, the ankle and foot, again, I'm going to direct you to that first part of the chapter, functional anatomy and biomechanics. Talks a lot about we've already talked about this in our own discussions of closed kinetic, open kinetic chain, our own discussions of gait and the foot abnormalities. We had our own, so that information is there, but it's good reinforcement. It's good. It's the same stuff. And then I do want to, like page 736, this is one area of the new edition of the text that is much more expanded. It gives a much more detailed description of the different arches, and they have this column and half dome kind of system to describe how the foot should be. Ultimately, when you see that functional demands of the foot and ankle complex on page 736, it goes through a lot of that normal biomechanics of gait that we've already talked about, but it's a nice review as you start to go through some of that situation and know that. On page 740, it starts talking about the general rehabilitation techniques, and then of course, as usual, you got to get through all those pictures. But this chapter is different from the other chapters in that there's kind of a general section, right? That 740 where it says rehab techniques for the foot and ankle complex, there's a general section of kind of a general, because it all overlaps. And so because of the functional demands, because of the instability of that, a lot of them are the same. We're going to do a lot of these single leg balance, a lot of these A lot of these activities are going to be focused on our functional activities, closed chain. When we strengthen, a lot of times we get a lot of good mileage out of our resistive, or especially manual resistance is a good. The ankle is a good place to do manual resistance because they're typically weaker muscles, and we have a little bit more control over what they do. As it kind of goes through there and it goes through the general stuff, on page 755, it talks about the difference of excessive pronation and supination. We've talked about this. I had the same or similar list in my other PowerPoints, but you need to know this, right? So the hyperpronation can cause a number of problems. You need to know this list. That is on, it starts talking about it on page 755. The hyperpronation problems are listed on page 756 and describes how some of that. So please make sure that you go through that. And then on the hypersupination problems, you have the same thing. And that's on page 758, where it talks again about when we have this, depending on if we are hypersupinated in the wrong portion of gait, then we have an issue that we need to deal with. All right. So from the only other besides the ankle sprain, right? So ankle sprains are pretty straightforward, and that's on page 767. Talks a little bit about that and some of the general stuff. The only other thing that I want to make sure that you're aware of is this chronic ankle instability concept, where basically a large portion of our lateral ankle sprain patients will develop a chronic ankle instability, just ongoing ankle symptoms, ankle sprains, or giving away episodes that may not even be painful. They just kind of give way. They give out. And so this goes back to that general rehab when you talk about the strength and the balance and making sure that we rehabilitate this person correctly. Not only do we have appropriate outcome measures to return them back to participation, but because these are endurance muscles, they can lose that endurance pretty easily. And so this is a lot of times somebody who has an ankle or chronic ankle instability or a number of ankle sprains needs to continue to do their ankle exercises long term and to work on these things right here. So make sure you have an idea of what chronic ankle instability is, the basic stuff on what we're going to work on. But that's pretty much it. Kind of a short one. I'll give you the gif of this person getting their ankles broken. Maybe he has chronic ankle instability, or maybe he just got out of position.